Thank you very much for that very kind introduction, and thank you for the invite. It's a real pleasure to be here at this course. I always tell my residents that I view Princess Margaret as the epicenter of all things liver radiation, so I feel a little bit like this is a pilgrimage for me to come up here and talk. And it's actually quite humbling for me to actually be giving talks like this one, knowing the depth and breadth of experience and development here at the Princess Margaret Hospital. What I'm going to be doing today is talking about radiation for cholangiocarcinoma. This is not meant to be a comprehensive overview of all things cholangiocarcinoma, but rather a thought experiment about why would we even be thinking about radiation for cholangiocarcinoma, some of the proof of concept that exists out there, and perhaps some ideas about where to go from here. So I think that it's important as a radiation oncologist, and as many of you in the room may have experienced in your own tumor boards, very similar to pancreatic cancer, radiation in cholangiocarcinoma is very controversial. And part of it is related to the stigma of radiation that's been attached vis-a-vis pancreatic cancer. If one thinks about pancreatic cancer, we can all look at the negative randomized trials that have been published since 2000, including the EORTC, which actually was in 1997, but the SBRT trial, FFCD, and the LAPO7 trial, where the local control benefit is highly questionable. And even if it weren't, there's a high metastatic rate in pancreatic cancer, and this obscures any overall survival signal that one can see with localized therapy with radiation therapy. Likewise, RTOG 0848, which is the randomized trial evaluating adjuvant chemoradiation for pancreatic cancer, is currently accruing, albeit somewhat slowly. Now, when we think about cholangiocarcinomas more specifically, the data, I think we would all acknowledge, is very poor quality. Predominantly, it's limited to single institution retrospective reviews or large databases with very limited single patient detail, like SEER databases. The patients that have been accrued in prospective trials are often a very small subset of patients in advanced technology phase 1 trials. And I think most importantly, biliary cancers are a mix of multiple different kinds of diseases. We consider hilar carcinoma or Klatskin tumors, distal bile duct cancers, and gallbladder cancers, which we think are different diseases, not just from the clinical perspective and patterns of failure, which I'll show in a minute, but also from a biologic perspective and the underpinnings of their genetic differences. And for this reason, when you have data of this very poor quality, I think it's not surprising that radiation is hard to make necessarily a strong rationale for routine recommendation. This is a nice review from Dr. Kim and colleagues about 5 years ago now, where he summarized in an adjuvant paper some of the data that exists for adjuvant therapy for extrahepatic biliary tract cancer. And what you can see here is, one, I will point out that these are all retrospective series, so it's not like these are prospective series compared to other prospective cohorts. They're certainly not randomized data. So you can imagine all the selection bias that may enter into a study of this any of these studies. For instance, perhaps patients with very favorable disease were declined radiation, higher risk patients received radiation, or vice versa. Maybe very sick patients weren't offered radiation, while patients who were more physically fit were offered radiation. This could cut either way, and the results can cut either way, but you can see here that we are talking in retrospective series about very small numbers, very heterogeneous survivals, and then mixed inclusion of tumors. But generally speaking, you can see here that many of the studies do not show an overall survival difference, but some of them do. But look how infrequently the fundamental question of what radiotherapy would be, local control, how infrequently it's been reported in a lot of the better, quote-unquote, better studies that exist in adjuvant radiation for cholangiocarcinoma. When people did try to look at larger databases like the SEER database, what you can see here is that there is, again, this is going to be prone to all the selection biases, that exist in any retrospective review. In this particular evaluation, you can see here a median overall survival for surgery plus radiotherapy of 16 months, surgery or radiotherapy alone, 9 months, no surgery or RT, 4 months. When I look at this, what I think is this is clearly just a palliative group where best supportive care was given, so I would just X that out. That's almost half the patients included in the study, right? So it says a lot about the type of patients that we're seeing with biliary cancers in general. They're often very sick from prolonged biliary obstruction, recurrent infections that preclude treatment, and you're left with these very limited evaluations of is there a benefit to radiotherapy or not. So again, historically, we have also thought that chemoradiation is quite hard. It's 5 to 6 weeks of radiation to the upper abdomen. And if you're thinking about adjuvant radiation therapy, it can be difficult after a large surgery like a Whipple or a extended hepatectomy for a Klatskin tumor. Additionally, besides liver transplantation, unlike the trend that we're starting to see in pancreatic cancer, neoadjuvant therapy still does not remain standard for biliary cancers. And for all these reasons, I think it's not hard to understand why I think we often struggle with really coming up with a concrete rationale for why one would think about radiation. Having said that and gotten all the negative information out of the way, just to be, fair, I think that it's important to recognize that cholangiocarcinoma is not pancreatic cancer. And I take care of a lot of pancreatic cancer. It's another one of my major interests. And I can tell you that even from taking care of these patients, pancreatic cancer really is not the same thing as a cholangiocarcinoma. I think, in fact, the only overlap is that for some patients, the surgery is the same. For a distant common bile duct tumor, it's a Whipple. And the presentation of jaundice is similar. But I would argue that the outcomes are different. Now, I think that you can argue, some people may nihilistically say survival less than 20% at 5 years is really not terribly worse than 30 to 40%, but I would say, well, it's kind of double for a distal cholangiocarcinoma. But the other thing is that pancreatic cancer is very much driven by distant metastases. At least 70 to 80%, some argue even higher, if one does not receive adjuvant chemotherapy, will develop metastases with pancreatic cancer. And I think that this is actually quite different than what one sees with extrahepatic cholangiocarcinoma. So this is one of my favorite papers on cholangiocarcinoma. It's not a radiotherapy paper. It's a patterns of failure paper from Memorial Sloan Kettering, Dr. Jarnigan, where he reviewed a number of patients who had either gallbladder cancer, in the top line, and extrahepatic cholangiocarcinoma in the bottom line. And this, I think, is really quite striking, that 38% of patients would recur with local-only recurrence, and a smaller percentage of patients would have distant recurrence. So you can see a dominant local recurrence pattern for extrahepatic cholangiocarcinoma, fewer patients with distant recurrence with or without local recurrence. Okay? Contrast that with gallbladder cancer, again, getting to the point that these biliary tree cancers are actually all very different. Gallbladder cancer, I personally tend to think of almost more like pancreatic cancer, where it's dominated by a distant pattern of recurrence, less of an issue of local recurrence. So I think that these patterns of failures really drive, for me at least, how do I think about radiotherapy and the impact of why would one consider radiation. Because even without survival data, as you've taken care of these patients with biliary cancers, when you have a local recurrence and you are not going to, in short time, succumb to metastatic systemic disease, this becomes a quality of life disaster. We've all taken care of patients where patients may have had a surgery, they develop local recurrence and biliary obstruction. Because they no longer have an intact distal biliary tree, it can be very hard to perform an ERCP back up the afferent limb and access the biliary system again. And then it turns out that the only way you can actually drain the patient is with percutaneous drainage. And we all know that patients who receive percutaneous drainage have a substantial risk of recurrent infections as well as substantial pain. And we, somewhat morbidly refer to this clinical scenario in our hospital as the Black Death, because it is such a terrible way to die. And I think that even if you don't have survival data, avoiding this scenario is an important quality of life measure, much like local control in rectal cancer, and trying to avoid a symptomatic recurrent issue. So the next question then is, if the patterns of failure are different and we can identify that there's perhaps a quality of life issue, the next question is then, will radiation actually work? Do we have any reason to think that radiation should be an effective modality in cholangiocarcinoma, and should we expect any differently from the hard lessons we've learned in pancreatic cancer? So to that, I think it's important then to evaluate the linchpin of what is the biology of cholangiocarcinoma. And I think that over the last 5 years, we've learned a number of things. This is one paper from our institution, but there have been multiple other papers, and there's going to be a TCGA report that's going to be coming out in the next couple months that are going to be looking at the heterogeneity of molecular aberrations in cholangiocarcinoma. But at least if one considers, as I had mentioned before, the biologic pattern of failure difference between cholangiocarcinoma and gallbladder cancer, you can see here that in blue we have cholangiocarcinoma, in green we have gallbladder cancer, and I'd like you to draw your attention to this column here. This is K-ras mutations. So this bar looks quite high, but this is only the 10% line. Okay, so if you take all comers with cholangiocarcinoma, the rate of K-ras mutations in all comers with cholangiocarcinoma is only 11%, and you contrast that with pancreatic cancer, where it's 90%. This is clearly a very different disease, in spite of the fact that it's a next-door neighbor to the pancreas. Additionally, one other point that I'd like to just point out is that if we look at gallbladder cancer, in gallbladder cancer we actually see PIK3CA mutations. We don't see that in cholangiocarcinoma, and you can see discrepancies in IDH mutations, only seen in cholangiocarcinoma. This is now known to be an important target in intrahepatic cholangiocarcinoma, along with FGFR, but this is really some early evidence that biliary cancers are different, and they're different from pancreatic cancer. Now, if one then separates out the intrahepatic and the extrahepatic cholangiocarcinomas, we see yet more differences in that IDH mutations are completely restricted to intrahepatic cholangiocarcinoma. And yes, we do see more mutant K-ras in extrahepatic cholangiocarcinoma, but still less than 25%, nothing even close to approaching the 90% rate that we see in pancreatic cancer. Now, I think that a natural question that you may ask is, why am I talking so much about mutant K-ras when this is supposed to be about, is radiotherapy effective or not in cholangiocarcinoma? And that gets me to my point that I think K-ras is probably one of the most important things that we need to understand better, get a better handle on in understanding radiation resistance in all models to radiation. So K-ras mutations predict for radiation resistance in multiple preclinical models, and clinical data does support poor radiation response to K-ras, and I'm going to show you some data to this point. So this is a review that Gillies McKenna, who spent the better part of a decade while he was at Penn, evaluating the impact of radiation resistance on mutant K-ras on radiation resistance. And this is a classic experiment he did in a colorectal line, DLD1. We had mutant K-ras and then in one allele, and then you can see the relative radiation resistance, and then he knocked out the allele and he restored radiation sensitivity. And this experiment has been repeated over and over again by multiple groups. What about the clinical data, though? Do we have any evidence that K-ras is important? This is another paper from Memorial Sloan Kettering where they evaluated 132 patients with stage 2 or 3 rectal cancer who received standard chemoradiation, and they evaluated 23 genes using standard Sanger sequencing. And what they found was that other than a rare cell cycling abnormality and a methyl tetrahydrofolate reductase mutation, which is a 5FU metabolism gene, the main conclusion was that if you had a pathologic complete response, you were statistically less likely to have mutant K-ras than if you had a non-pathologic complete response. In other words, the group of patients that did not have a path CR had higher rates of K-ras mutation. And we reproduced this observation at MGH with a smaller cohort where we evaluated 47 patients treated with standard 5FU radiation and did their genotyping. And only one RAS mutation that was treated in this cohort had a pathologic complete response, when in the rest of the cohort we had about a 24% pathologic complete response rate, again highlighting the impact of mutant K-ras, at least in rectal cancer. Well, is it just a rectal cancer specific phenomenon? Probably not, in that mutant K-ras in a paper that was from the Dana-Farber evaluating SBRT and stratifying by K-ras status demonstrated with lung SBRT that mutant K-ras was associated with a worse local control rate. We also evaluated this in a prospective phase 2 study evaluating individualized dosing of protons for liver metastases. I'll show more of this data tomorrow when we talk about protons in liver tumors. But one of the things that we looked at was, could we predict who was going to have local control or local failure at 1 year? And unlike some of the data that Laura showed in her talk about liver metastases, we were not able to demonstrate a dose response, nor were we able to demonstrate an impact of tumor size, nor were we able to demonstrate an impact of local control based on whether or not the disease was controlled or progressing at the time of entry into the study. The only thing that predicted for local failure at 1 year was mutant K-ras status. So you can see, look how bad our 1 year local control is in a K-ras mutant patient. It's 47% as opposed to 77%. I'll tell you that we did treat a lot of colorectal patients, but some pancreas patients, and some of my longest term survivors are actually K-ras wild type pancreatic cancer patients. Right? They have local control after this. So it's not just the disease type. It turned out that the site of origin was not predictive. It was just K-ras mutant status. And then this is graphically depicted in this cumulative incidence function here. And you can see that this did reach statistical significance. So getting back to the bulk of the issue of radiotherapy and cholangiocarcinoma, what I would say is that the data is not that high quality, and the RT techniques often vary widely, but I do want to highlight a couple what I think are important proofs of concept about the efficacy of radiotherapy in cholangiocarcinoma, and I'm going to separate out intrahepatic and extrahepatic cholangiocarcinoma. So I'm going to start first with extrahepatic cholangiocarcinoma, and what I would call, in spite of the fact that they would have liver transplants, so resectable, really unresectable patients who were treated in the Mayo Clinic transplant program. And as you know, this is a highly controversial data set. Many of you may know that these were patients with small tumors, less than 3 centimeters in size, who were also very carefully staged. The Mayo Clinic will do endoscopic ultrasound, will biopsy all lymph nodes they see, not just ones that are pathologically enlarged, to ensure that they're N0, and they will start them down this path of external beam radiation to 45 gray, followed by an intraluminal brachytherapy boost of 20 to 30 gray with 5FU, and they continue on a maintenance therapy until the time of their transplantation. And clearly, what everyone focuses on is the high 5-year survival in those who actually make it to orthotopic liver transplantation. But what I would actually highlight is the fact that 16 of 38 patients of the explanted patients had no residual tumor. And when you actually think about it, the dose that they were giving, which is actually fairly high when you include the brachytherapy boost, the fact is that these pathologic complete response rates are very similar to diseases that we see where we know radiation works, like esophageal cancer or rectal cancer. So I think that this is a nice proof of concept that you can actually sterilize disease. And then you can see that in the updated series that they do continue to see fairly good results. This always is the main issue, that so many patients are removed due to progression. And the 5-year intent to treat overall survival is only 55% as opposed to 71% after orthotopic liver transplantation. And then this is not a fluke. This is another combined analysis from 12 centers. And again, in 54% of patients, no tumor visible on pathology. So again, with radiotherapy, you can actually get to a point of no disease. The liver transplantation is almost like a surgical salvage for the damage that's been done by the radiotherapy. So what about adjuvant therapy? I think that we're all well aware of that the most current data is the SWOG trial that Edgar Ben-Joseph recently published in JCO. What's great about this study is that it was a prospective study, multi-institution with radiation review. What makes it very typical for a cholangiocarcinoma study is that it's a mix of a lot of different diseases again, extrahepatic cholangio as well as gallbladder cancer. Important to note that they did allow R1 resection, which I think is a very appropriate entry criteria. And this here is the data that you can see, and this median survival here compares very favorably to historical controls, reaching to about 30 months. But this, I think, is actually the most interesting thing about a group of patients who all received chemoradiation. It actually surprises me a little bit about why the first clinical trial design that one considered out of the SWOG group was plus or minus radiation, is that R1 is the most consistent adverse risk factor that one sees in resected cholangiocarcinoma, but when you give high-quality radiotherapy, the impact on overall survival goes away, telling me that the radiotherapy does do something, and as we talked about, this is a very different biological group than pancreatic cancer, and I think that this is proof to me that radiotherapy is actually effective in cholangiocarcinoma. And I think that this is well borne out in how low the local recurrence rates are here. If you add these up together, it's 21%. If you recall from the Memorial Sloan Kettering series, this number should have been 40%. So, we all use rules of thumb about what does adjuvant chemoradiation get you. I always think about somewhere between a 1/3 to 1/2 risk reduction. Again, it's not fair to look at two different data sets, but this is about what you'd expect. It's about a 1/2 risk reduction in local failure, suggesting to me that if you do your radiotherapy right, you can actually impact local failure in the adjuvant setting. In the last few minutes, what I'd like to do is talk about intrahepatic cholangiocarcinoma. This is a disease that we've historically had less of a role in managing. And again, I just want to highlight the fact that if you look at intrahepatic versus extrahepatic cholangiocarcinoma, now this is a group with a very low rate of K-ras mutation, less than 5% rate of K-ras mutation. And we did a phase 2 study that I'll talk a little bit more about tomorrow, where we looked at patients with both HCC or ICC. The statistics were actually benchmarked to an 80% 2-year local control for HCC, and then a similar estimate for intrahepatic cholangiocarcinoma, recognizing that we didn't really have a historical control for how are we supposed to do with radiotherapy for intrahepatic cholangiocarcinoma. They received 15 fractions and 67 to 67.5 gray. And what you can see here is that at 2 years, the local control for all comers, whether you had intrahepatic cholangio or not, or HCC, was 95%. But unlike HCC, there are late failures in intrahepatic cholangiocarcinoma. And I think that what ultimately matters is, can you get enough dose in? If the BED is greater than 80, this is a paper that just came out from MD Anderson that we worked with them. Basically, Chris Crane took our 15 fraction schedule, and these are all the patients he treated off study with photons in the high dose arm, and these are what he used to do with standard chemoradiation. And you can see that we are able to now have high degrees of local control, very similar to our phase 2 data, and this actually leads to some patients surviving their cancer for a prolonged period of time. And one of the cases that we have on Saturday will be an intrahepatic cholangiocarcinoma treated on study. So in conclusion, I would say that the role of radiation remains unproven for cholangiocarcinoma, but I would also say that what we know about the clinical risk and the significance of local failure suggests that there is room to improve. What I hope you take away from this, and we can bring back to your tumor boards, is the majority of cholangiocarcinomas are actually K-ras wild type, portending potentially a better responsiveness to radiation therapy. And the emerging data suggests that for intrahepatic and extrahepatic cholangiocarcinoma, now in prospective trials, suggests that radiotherapy can actually be quite effective in cholangiocarcinoma. And I think it's important to continue to support randomized trials as they are activating. Thank you very much for your time.